Like they just scroll through.
Can I see? Hello. Hello.
Hi, ma'am, you are audible.
Yes,
Am I
Aparajita.
audible? Okay.
Yes, Aparajita, you're audible.
Okay, fine. I'll just once I'll share. Okay. Okay, and I think I'm visible also.
Yes, you're visible.
Okay. And if I share, just a minute. I just want to see if everything is fine. Sujata Devi, help me out. Swapna. Oh, take that.
Ask them to see the screen.
Can you see the screen? Can you see?
No.
No. Okay. Just a minute.
Just need to click on green button and then you need to select the window.
Right, screen sharing. I'm sharing my screen. Start now. And one second, let me go to file manager.
No, file manager must be shown for the apps.
No. Okay, Microsoft. Excellent. I'll go to Microsoft.
Another.
And it's not taking it. What do I do? Wait. So where is it now?
Now try sharing.
I'm trying to share.
Screen.
Where is it gone?
Is it visible? It comes right here. Ask Shweta.
Shweta, is it visible? I don't know if I'm audible also. Am I muted
You
or
are
unmuted?
audible, but I
Screen
don't
share?
think the screen is visible.
Screen isn't
I
visible.
cannot see.
Okay. Anyone else?
No, ma'am. Screen sharing has not been done yet. Your screen is not visible.
Screen is not visible. Okay.
No.
Should I get the Chromebook?
Have you clicked on the green button at the bottom of the screen at the middle? Share screen.
Yeah. Share screen I've done.
Then
I've done
you
share
choose the
screen.
window which you want to select. You have to choose the window which you want to share.
Yeah, I have. Wait.
Zoom.
Zoom. Settings. Okay, how does it help me? Let me get my Chromebook. Just a minute. I'm logging in from another system. Rooney, I might require your help.
So I think Aparajita's screen is now being shared, is it?
What is the screen sharing option?
Yes, Aparajita, I think your screen is being shared right now. I can see it right now.
You can see it right now.
Yes.
Are the slides changing?
It is visible right
We
now.
can see it's visible.
Yes, it's visible now.
Okay. The problem is I am not sure what did I do. Should I just leave it at this stage? No, but then
No, Aparajita, if you leave it at this stage,
I'll
with the
always be
display,
showing
then
up
you
this way.
cannot change your slides.
No,
we can.
I'm changing.
Are the slides changing?
Slides are changing. Slides are changing.
Yes,
Yes.
slides are changing right now.
Yes.
This will go.
Huh.
This will.
But
Yes.
but then I need to be visible with that. Excellent. Shweta, I'm starting again. Okay, I'll just stop sharing once.
Yes.
Don't do that. No, but then I
Yes.
need visible ones.
Yes, yes, it's visible now.
No, but then what I'm concerned is, wait.
You are still sharing your screen?
Yeah, I am.
Yes, you're still sharing your screen.
Just a minute. Now, am I visible now? It is me who is visible, or it is the
Yes.
presentation?
No, no, you are visible.
I'm visible. Okay.
Yes.
There. Now the slide is visible.
Yes, now the slide is visible.
Okay.
So just start with that and shift it over.
That's it. I hope it's going to work. No, but is it an issue if I'm this way?
For now, you need to stop sharing, ma'am. Otherwise,
Now I need to stop sharing.
yeah. Once again, while you'll be having your session, you can once again share the screen.
I think you have already stopped sharing, no?
No,
No,
I
ma'am,
haven't.
it has not
No,
been. It
no,
is still
no.
on the screen.
Oh,
ma'am.
you're still sharing, yes.
I'll try it once.
Actually, you have selected Zoom screen. That's why it is showing your screen only.
One of the
You
systems.
just need to stop sharing.
I'll stop sharing and then I'll restart sharing. I'll check.
Yeah, now screen sharing has been
I'll
stopped.
stop sharing. Now I'll again try sharing. Okay. Just check if it
Sure.
happens.
Yes, sir.
Yes.
Problem is I cannot open this. Now?
Yeah, it's perfectly okay. It's coming.
Fine.
Just keep it minimized.
But then I'll have to stop
Go
sharing
to this
currently.
window, stop sharing, and again start sharing.
That's fine. I can minimize your system. Cannot minimize your system. Currently, I'm stopping sharing. Okay.
Yeah. The screen share has been stopped. Okay.
I'll check. No, I can just share what
Take
you
it.
want. Okay, I'll just stop video.
Just leave it like that.
And,
Okay, I'm ready, sort of.
okay, just one thing for Shomoduti. Dr. Neena Madam's sister is unwell and admitted in the ICU. So she might not be able to join on time. So yours is going to be the second lecture after Aparajita. Shomoduti, can you hear me?
Mine, ma'am. Yes, ma'am.
Shomoduti, your lecture
Yes,
is
ma'am.
going, might be that your lecture is going to be the second one, not the third one as scheduled before. In case Neena Madam is late and cannot make it by time, so your lecture will be second and Neena Madam's will be third.
Okay,
Okay?
ma'am. Shall I share my screen once to show?
Yes.
Is it visible, ma'am?
Yes, yes. Yes, visible. I think Neena Madam has joined.
Yeah, I have. Can you hear me?
Ma'am, I hope your sister is better.
She's in the ICU. I'm sitting in the ICU and doing this webinar. They've given me a little place to do it.
Very nice of you, ma'am.
There's still 8
Nina,
minutes
this
now.
is
This is Kaushik. I don't have what to salute your commitment. I'm not a part of this program. I just joined, and salute. Really, my voices are choked. I'm sure your sister will be fine very soon. Thank you, and have a great evening.
Thank you. Thank you.
Yes, ma'am.
Can I just try sharing my screen?
Yes,
Because
ma'am.
we have little time.
Yes, ma'am.
You can see it?
Yes, ma'am.
Okay. I'll just do slideshow. Okay. Yeah.
Yes, we can see.
Okay. Good. Thank you. So I'll just stop.
Ma'am, so you are the second speaker.
Yeah.
Okay.
Yeah.
Yes, ma'am.
Hi, Dr. Dinesh.
Hello, Neena ma'am.
And Dr. Sudeep
Good-
Das. Good evening.
Good
morning,
sir,
madam.
sister,
Good
speedy
evening, madam.
recovery.
Good evening, madam.
Good evening.
Nice
Good
to
evening.
see you in the program.
Thank you.
Dinesh Da, welcome.
Yes. Yeah.
Is our secretary in? Suchi Broto.
Dr. Das, good
Yes,
evening.
Good evening, ma'am.
And of
Okay.
course, Dr. Sujata has been coordinating so nicely. And Dr. Panda, good evening.
Good evening,
So
ma'am.
this is one of our flagship programs, and what the best part of it is that this is totally organized by a women's dermatology wing of the West Bengal IDFL. So that is the best point, and Dr. Sujata has carefully integrated the program. She has all planned the program to find contacted you all, and here we are going to reap the fruit today.
Very
So,
great coordination.
I must thank Dr. Sujata for taking all the efforts of this coordination and all the trouble of doing this.
Thank you, Shudipta, for your nice words. And I
I mean,
thank
you have done wonderful job. I know it is how painful because the last 3 I have done. So this one I had been really silent on this. I didn't do anything, but you have done a wonderful job.
I think all these programs are very difficult to organize.
Yeah, if we are organizing it, let us see. This is the 4th program in the row. This is the 4th program in the row.
Okay. I think each topic is 15 minutes.
I think 15 minutes each. Sujata, am I correct?
Yes, 15 minutes of talk each. And then the panel discussion.
Yeah. Total 1.5 hour program.
1.5
That is
hours.
Okay.
The first 3 had been very successful on dermatopathology, STI, and leprosy. We had it. So hope this will also have that same rubber stamp of success. It was widely appreciated by all the faculty nationwide, what we did from the WhatsApp groups. So let us have it. This is one of the flagship programs. Madam, you can share your screen, and those who have not shared, please do share your screens.
I think all of them have shared already.
Yeah, I did.
Okay,
I
okay,
shared.
Okay.
Yes. Maitreyi, you tried, right? Maitreyi has also tried?
Yes, ma'am.
Okay.
Oh. Good evening, Maitri.
Good evening, sir.
Good evening.
Yes, Shudipta, we also have Dr. Abhinita.
I'm not seen it. Abhinita?
Yes, sir. Good evening, sir.
Good evening. Good evening. Good
Yes.
evening.
And
Good evening.
is Shreya on board yet?
Shreya is the moderator, na?
No, Shreya.
Yeah.
Maitreyi is the moderator. Shreya is a panelist.
Okay. And the other panelists have joined. I can see Ye there. Just now saw.
Yes, Shreya is joining. Yes,
Sujata,
welcome, Shreya. Yes, Shreya has joined. So we have everyone on board. So, Shudipta, can we start? Dinesh da?
Yes, Dineshda will start the lay because Dineshda, I'll invite Dr. Dinesh Havali, our president-elect, to start the proceedings. He will tell what is Derma Adhyayan and why we require it. Why we require it, that is a very important. That is very important. So let Dineshda start the program. Then
You
we'll
just tell me when to start.
Yes, I think
8:30. 2 minutes left. 2 minutes left, I think. 2 minutes
Fine.
left. We start at 8:30. Soumyaduty's CV can Sujata
Yes,
di
ma'am. Sir, I'm
थोड़ा सा मेरे
I
को
don't,
WhatsApp कर दो.
I don't have any of the CVs.
Oh, Soumyaduty. तो क्या हमें इंट्रोड्यूस कर दो
sir,
यानी?
ma'am, I have
Shall I
sent you.
send Shomodu? I have Shomoduti's. I
Yes,
can send. Yes, I'll send Shomoduti's.
ma'am, I have sent you.
Okay.
Yes,
Soumyaduty
yes,
আমাকে একটা ফরওয়ার্ড করে দাও না, ফরওয়ার্ড করে দাও.
I'm
Soumyadutyটা আমার
sending
কাছে
it
নেই.
to you. I'll send it to you.
In this gap, may I just take a few minutes to just announce one thing? Actually, 25th of June, we're going to arrange another webinar on Vitiligo Day. National faculties like Professor Shomesh Gupta and local faculties all will deliver their insights. So all are requested to attend the webinar. Thank you.
That's great, Suchibrata. Great information. So we are going out this time. We normally have our OPD basis camps and all these things, but this time we are going ahead of it.
Shudipta, have you received?
I have received. I've received. I've received.
So you have all the CVs with you, Shudipta. So you are in charge of the CVs,
definitely.
right? Okay.
Definitely, I won't tell you. Dinesh, I think 8:30 ho gaya. You can start.
Oh yeah. May I start now?
Yes.
So that, now we live. Is the technical team here?
The practical team is already
It's
given
already
live.
live, ma'am. It's already live.
Already
and
live.
The session is also on record. So you can start the session.
So hello everyone. Let me tell you that our president, Dr. Sandeep Bandhar, is today not available because of his personal preoccupations. So I will be introducing today's webinar as of now. As all of you know that IDBL West Bengal State Branch always organizes academic activities regularly, and we are really hell-bent on doing this. This time, Derma Adhyayan, which is a flagship academic endeavor of our branch, has been very successful in last 3 episodes, and we have selected common topics which will be of interest to common practitioners, PGTs, and all those who are interested in dermatology. In their busy practice, they may not get time. So on Sunday evening, they can spare 1 to 1.5 hours to brush up their common disease presentations, etc. And we have chosen common topics all the time. This time, or on the 4th episode, acne has been selected as a topic. And we had a very successful previous 3 episodes on STI, leprosy, and one more topic. And that was stupendously successful. And common STIs, I know. And so today acne will be dealt with, and all the esteemed speakers will put some light on that so that we can brush up our knowledge, so that at the end we'll be able to treat patients in a better way. So I'll hand over to Dr. Sudeep Das for introduction of the speakers.
Thank you, Dinesh da. We'll start away with the Dr. Nina Madani. And thank you, madam, that in spite of personal problems and I salute you for being in the program. She is attached with a consultant dermatologist in the Hinduja Hospital and HN Reliance Hospital, Mumbai. He's the reviewer of multiple journals, including our IGDVL, IGD, JCAS, and other things. She was the coordinator of SIG acne appendages, now a member, past member, coordinator of first special interest group on female genital disease, now also a member, published several articles in peer-reviewed journals, and published Atlas on vulvovaginal disease and darker skin types in 2023. She had delivered 4 orations a lectureship in the Canadian Dermatology Association. So, welcome Dr. Nina Madani.
Thank
Then
you.
I will, Madam, please take our warm welcome for us. We also have Ovinita Hastota. She is a professor and head of the department of the Oxford Medical College and Hospital, Bangalore. She is the secretary of the Psychodermatologists Association of India, and also the best research work awards for the subcutaneous panniculitis, like T cell lymphoma and mycosis fungoides. That was she got the best research award for that. She also received the Rising Star Scholarship in WCD 2019 and ICD 2021. Welcome, Madam Ovinita.
Thank you, sir.
Welcome for being a part of our endeavor.
Thank you,
Maitri, we know Maitri is a part we frequently meet in the eastern part. Maitri is a frequent. She's also now the secretary of the AC of the ISPD. She has 15 years MD, post MD experience, professor of the IMS and SAM Hospital of SOA University in Bhubaneswar. Maitri has 110 publications, editor of 5 books. She is honorary secretary of ISPD, associate editor of the IGSA, recipient of IDVL Research Grant 2023, member of the National IDVL Academy, member of National SIG Pediatric Dermatology, convener of the National SIG Pediatric Dermatology in 2022 and 23, and recipient of Academic Achiever of Dermatology Celebration in 2021 in SCB Cuttack. And also she is the recipient of IADVL Ellen Sinha Memorial Award. So welcome Maitri to our program.
Thank you, sir.
And thank you for being a part of our program. And now I will sing our own Sujata Di. I will introduce last because she needs no introduction. I would start with introduction of Somuduti Chandra, who happens to be one of my students in her days when I was in medical college. She is now consultant at Medica Super Specialty Hospital, Kolkata, and Wisdom Specialty Clinic. She has 17 publications and 20 presentations. She has F. Handa Award for the best paper for the award paper in Dermacon 2017, gold medal in Amarkant Jha Memorial Award for the best award paper presentation in the 14th Derma Zone, certificate of excellence for the poster presentation for IZD DiamondCon Derma Zone East Cuticon, gold medal for PG students in medical college for the session 2014 to 2017, NB Das Memorial Award for obtaining the highest marks in MD Dermatology of West Bengal Health University in 2017, and gold medal in Dermatology 2017, West Bengal Health University. So welcome, Somuduti. Somuduti, are you there? Then
Yes,
we
sir.
have also, okay. Then we have our own Shreya Poddar. Shreya is also, she has passed out from the BGMC Ahmedabad. Now, then she did her MD from IPGMR, DNB, and now fellow MNMS, fellowship in aesthetics and laser, publication and authorship. Authorships are 14. She is the editor of Skin Intellect, which is our monthly newsletter of the IDVL West Bengal. She is a member of the PDS Academy 2024 to 2025, currently practicing in Kolkata. So welcome Shreya on board. Now I will introduce Shreya. I hope you are already joined.
Yes, sir. I'm here.
Okay, thank you. Next I will introduce Aparajita Ghosh, who is along with Dr. Sujata is working in the same college. She is associate professor there. She has 20 publications and 10 presentations. She got the WCD Rising Star Scholarship for 23rd World Congress of Dermatology 2015. Best paper in award category Dermazone 208. Awarded the best postgraduate training in dermatology in 2009 and the first position of IDVL GSK quiz in 2007 and 8. She is also the section editor of IJDVL and currently deputy editor of IJD. And now, for last, but definitely not the least, the most important, I will tell, Dr. Sujata Sengupta, who is a professor and head of the KPC Medical College. She is MBBS and DCH from NRS Medical College, MD DVL from SCB Cuttack, Best Postgraduate Paper Award in Kutikon, Odisha in 2001, published 48, authorship in 7 books, including IDVL Textbook of Dermatology, member of editorial board, Pigment International Journal, member of SIG Female Genital Dermatosis, reviewer of IJDVL, IGD, IGPD, IDOS, areas of interest are clinical dermatology, female genital dermatosis. So with that, I thank all the West Bengal members, including Shreya, Shomoduti, Aparajita, and Sujata for this program, for organizing this program, and also our guest faculties are most welcome for the. I request Sujata to take over. Sujata, take over and go ahead with the next sequence of events. Let us start the lectures without much delay. Sujata di.
Yes, so welcome you all. Without much delay, we shall be starting. So as you know, today's expert faculty, which comprises of an all-women brigade, and they will enlighten us with 3 lectures followed by a panel discussion. So I welcome all the speakers, the moderator and the panelists. So I think first Dr. Aparajita Ghosh will speak on newer insights into the pathogenesis of acne. Over to you, Aparajita.
Thank you, Shriyata Di. So I'll start presenting. Is my screen visible, please?
Not yet.
Not yet.
Not yet. Okay, just a minute. Is it?
Yes, yes.
Now it was coming. Just gone away again.
Just a minute.
It was coming.
It was, yes.
Yeah.
I just,
yes.
Sorry for the glitch. Good evening, everybody. In today's presentation, I'll briefly touch upon the relatively recent insights into the pathogenesis of acne. Now, this is a very rapidly evolving field, and concepts and information are accumulating so fast that we often feel flooded and bogged down by their amount. So I have tried my best to summarize in short what I myself could learn and understand, and I hope you'll find this presentation useful. So now acne is a common and chronic disorder of the pilosebaceous unit and is caused by multiple factors. There's nothing new in this. We have always known that seborrhea and change in composition of sebum, then follicular plugging, presence of Cutibacterium acne, and release of inflammatory mediators together, work together to cause acne. But there is a slight change in the recent outlook. So it differs from the previous one in certain points. So instead of placing all the blame on Cutibacterium acne, the researchers now say that it is the overall alteration in the microbiome or the microbiological environment that is responsible for causing acne. Also, the role of inflammation has gained more prominence, with newer molecules and newer pathways being revealed, and inflammation in acne is now being considered a part of a systemic immune activation. So inflammation now is considered as the primary factor in pathogenesis of acne. It is supposed to be present in all stages of acne lesions and has been documented from initial microcomedone to scars. In fact, indeed, upregulated immune inflammatory mediators have been found in like cytokines, interleukins, etc. have been found even in both involved and non-involved skin in acne patients. So now coming to the cellular mediators of inflammation. So these are the cells of our immune system which mediate the inflammation, and certain studies have actually documented the timeline of appearance of different cell lineages in the evolving acne lesions. It was seen that the CD4 T helper cells are the major leukocytes which appear early on, that is within 6 to 72 hours, along with some CD1 plus dendritic cells. Next appear neutrophils, which appear in pustules around, after 24 to 72 hours. And the CD8 plus T cells are observed in the lesion much later. These, the roles of lymphocytes and neutrophils have long been recognized. But what was surprising in these new studies was the role of mast cell. It was actually that the mast cells were found to be plentiful even at the stage of microcomedones, and thus appears to be one of the earliest immune cells to be activated. The macrophages too have now received a lot of attention as being the cells with the dual ability of being able to resolve or being able to aggravate the acne lesions. Now, as we know, the major function of macrophages are phagocytosis of pathogens, clearing of cellular debris, secretion of inflammatory mediators, and immune activation of T cells. So their role in acne pathogenesis is very interesting. They play a paradoxical role in acne development, serving as both sentinels and provocators. Their functions include regulation of lipid concentration, and they facilitate the elimination of Cutibacterium acne. However, when the immune reaction is not controlled or more than moderate, it can provoke severe inflammation and subsequent acne scarring. So macrophages appear to be very important in the residual scarring that we see after acne. So interestingly, it has been observed that squalene, as we know, squalene is present in high amount in sebum of acne patients. So it is seen that squalene in the sebum upregulates the expression of TREM2 on macrophages. Now, TREM2 expression increases the survival of macrophages and their phagocytic capacity. Their microbicidal action, the microbicidal action of macrophages, they depend on the release of reactive oxygen species inside the vacuoles. However, paradoxically, squalene itself is a scavenger of reactive oxygen species. So it thus prevents the macrophages from killing the Cutibacterium acne that it is already engulfed. So now these TREM2 macrophages are now loaded with bacteria and squalene, bacteria which they cannot digest because they have a low microbicidal capacity, but because their survival is increased, they can secrete a lot of inflammatory mediators and thus increases the inflammation and scarring. So in this way, a macrophage can actually, instead of resolution, it can help in aggravating acne lesions. So this is something which I've already described. Now, the role of T cells have always been recognized. But earlier, our concept was that a helper T cell would differentiate into the Th1 and the Th2 pathway. Those were the two very important pathways that we had all learned. But much later, relatively recently, the Th17 pathway has been elucidated, and it has found to be important in quite a few systemic diseases and cutaneous dermatosis also. The production of interleukin 17 and other cytokines of the Th17 axis appears to be central to the pathogenesis of acne. Inflammatory host factors, let's come to the pathogen. Now, regarding the pathological agent, the concept of causation of acne by a single pathogen is increasingly being replaced by the concept of cutaneous dysbiosis as a causative factor. So, in short, if I am to introduce you to what is a microbiome and what is dysbiosis, let us see that we know in normal conditions, our skin has millions of commensal resident microbes, which consist of bacteria, fungi, viruses, protists, etc. The skin also has certain niche environments, like the individual pilosebaceous units, where certain organisms might predominate. Under normal conditions, the relative proportion of these different organisms and even the different phyla of similar species are maintained in a narrow homeostatic range. But a change in this proportion might occur, and this is known as dysbiosis. And it is now considered an important driving factor in quite a few cutaneous diseases. So the normal typical flora of the skin consists of actinobacteria, firmicutes, proteobacteria, and bacteroids, and of course the Malassezia species. So in simple language, what I would want to say that microorganisms that inhabit the healthy sebaceous follicle consist of 3 distinct microbial groups that coexist. You can find the coagulation negative staphylococci, such as Staphylococcus epidermidis, the anaerobic diphtheroids, which include the Cutibacterium acne, and a similar species, Cutibacterium granulosus, and yeasts that thrive in this oily environment, like the Malassezia species. Now, in case of acne, it has been documented that not only there is a dysbiosis regarding the change in composition of the different species, but even amongst the phylotypes of Cutibacterium acne, there is a change in proportion. Cutibacterium acne strains are classified classically into 6 main phylotypes. The 1A1, 1A2, 1B, 1C2, and 3. This is based on the genomic sequencing. Now, it has been seen that in acne-prone skin or in acne lesions, it is now associated with loss of this phylotype diversity. And Cutibacterium acne phylotype 1A1 becomes more predominant, amounting up to almost 70% instead of 40%. The phylotype 3 is found only in healthy skin and is missing from acne involved skin. And the phylotype 1C is typically found only in acne skin. So other than the difference in phylotypes, the ratio of the Cutibacterium acne to a related similar species, that Cutibacterium granulosum, also is important. Acne patients have typically a lower relative population of Cutibacterium granulosus. Now, Cutibacterium acne and granulosus have been reported to exist in a similar environment, so they are potentially competitors to each other. So, it has been found that Cutibacterium granulosus secretes an endogenous nuclease which is capable of degrading the Cutibacterium acne biofilm. I'll come later to the importance of biofilm, but we already know that there's biofilm formation is an important virulence factor of Cutibacterium acne. So, lowering of the population of Cutibacterium granulosus leads to an obvious increase in population of Cutibacterium acne. Also, a relative abundance of Malassezia species has been found with, and the species is known to have 100-fold more active lipase activity than Cutibacterium acne, and thus is capable of inducing much more severe inflammation. So other than the skin, so the concept of dysbiosis also extends to the gut, and this is known as the skin-gut axis. There is also a skin-gut-brain axis, but for the sake of brevity, I have just confined myself to skin and gut only. So coming to the gut microbiome, just like the skin, the gut has its own resident microbes, and a change in that proportion is known as gut dysbiosis, and is implicated in quite a few chronic skin disorders. Now, the host physiology, the genetics, and the chronic antibiotic use, stress, a Western diet with high glycemic index, underlying disease, etc., all of them decrease the gut microbial diversity and a loss of commensals like Faecalibacterium and Clostridials. Just like we have a skin barrier function, we also have a gut barrier, and this leads to diminished intestinal barrier and increased leakage of lipopolysaccharide endotoxins into the circulation, and a generalized overall inflammatory response through the toll-like receptors 4 and CD14. Now, other than the host factors, if we come to this, we come to look at the pathogen. Now, in spite of all this discussion on cutaneous dysbiosis, the importance of Cutibacterium acne cannot be underestimated. So let's have a look at the virulence factors of this bacterium. First and foremost, it is the biofilm formation, which protects the bacterium from antibiotics and other bactericidal agents. The biofilm also acts like a biological glue, which causes this keratinocyte adhesion and follicular plugging. We know, as I already discussed, that the phylotypes 1A1 and 1A2 are the most commonly implicated in acne pathogenesis, and it has been seen that they exhibit the highest and most complex biofilm formation. Now, other than biofilm also, Cutibacterium acne is a strong activator of toll-like receptor. specifically TLR2, and these TLRs have now become central to the pathogenesis of acne, and especially the activation of innate immune system. These TLRs are pattern receptors which can recognize the glycoprotein sequences on the bacteria, and then they dimerize to activate the NF-κB, that is the nuclear factor kappa beta, and this results in production of pro-inflammatory cytokines. These TLRs are present on keratinocytes, sebocytes, neutrophils, macrophages, and also the T cells. Now, once the TLRs have activated, and this pro-inflammatory cytokines of IL-6, IL-8, TGF-beta, and IL-1 beta have been secreted by these above-mentioned cells, this induces the differentiation of CD4 naive T cells into T17 T helper cells. And once these T helper cells are active, it in turn activates and release IL-17, IL-21, IL-22, CCL20, which is important in the Th17 axis, which is central to the pathogenesis of acne. A concomitant decrease in interleukin 10 and interleukin 4, which have anti-inflammatory effect, has also been seen. Now, the other two molecules, which have recently gained a lot of attention and a lot of importance, are the mTOR1, which is the mammalian receptor for rapamycin, and the FOXO. So Forkhead box O molecule. So these respond to the IGF, or insulin dependent growth factor receptor. What has been seen that mTOR1 is activated by the IGF receptor activation via the MAPK pathway. And once mTOR is activated, it secretes SREBP1, and that increases the lipid synthesis and substance P release, and it it increases the inflammation. The FOXO1, on the other hand, is a molecule which is known to induce apoptosis. It deactivates the mTOR via the AMPK pathway and generally acts as an anti-inflammatory agent. So these insulin-like growth factors, they actually inhibit FOXO1, and they activate mTOR1, and this differential activation leads to causation of acne. So now there are several systemic factors which influence the pathogenesis. We are aware of quite a few of them. I've already discussed microbiome. The hormones, we are well aware of the role of androgens. Then stress, oxidative stress, diet and metabolism, and genetic factors. I'll just briefly touch upon them. The psychological stress, as I talked about the skin, gut, and brain axis, the skin actively responds to stress through neurotransmitter, cellular immune responses, and hormonal fluctuations. Now, it's a vicious cycle. The more acne a patient gets, the more stressed the person is, and this sort of, propagates further. The majority of the stress-induced response is mediated by the substance P, which is a key neuroinflammatory mediator, and leads to expression of pro-inflammatory cytokines of interleukin-1, 6, and TNF-alpha. Now, regarding the diet-induced acne, the role of diet, though not completely proved, has long been suspected. The mechanism has, however, been recently demonstrated. It is said that high glycemic index food, more common in the Western diet, and dairy products, etc., they lead to secretion of insulin and insulin-like growth factors. And as I had pointed out in the previous mechanism, they activate the mTOR1 while they inhibit the FOXO1. So overall, an activated mTOR and decreased FOXO1 leads to increased sebaceous lipogenesis, more fatty acid, more secretion of lipases, more fatty acid synthesis, which in themselves formation of inflammasomes, and they in themselves can lead to inflammation and comedone formation.
Yes, Aparajita, sorry to interrupt. You have 2 more minutes.
2 more minutes. I'm almost done. So I will more or less just the zinc has a protective role. Now, homocysteine has been shown to be markedly elevated in patients with acne. homocysteine is inhibited by folate, but the significance is still not known. Now, regarding hormones, it is already known, so I'd better skip. Coming to oxidative stress, exposure to environmental pollutants, irritants, as well as UV radiation leads to accumulation of reactive oxygen species, and this leads to oxidation of lipids, which are very highly pro-inflammatory agents. So, coming to the genetic influence of acne pathogenesis, as we see the pathway of inflammation, almost every possible gene which could be involved in the pathway of inflammation have been studied. It is, of course, acne is not caused by a single gene. It is obviously a polygenic inheritance and more due to interplay between multiple genes and environmental factors. The genetic influence of acne is still under evaluation, and because a lot of studies have been done with a lot of genes, but most of them have focused on single nucleotide polymorphism or tandem repeats, and these are isolated reports. Many of them have to be duplicated to be able to say if there is really some very distinctive association. So most studies are the interleukin gene, the tumor necrosis factor genes, the resisting gene, the cytochrome P family gene. The other genes seen are, of course, the insulin-like growth factor, toll-like receptor gene, and the MAPK11, and several that I have noted down here. These are the certain references that I have gone through. Not all, but these are quite a few of them which I've gone through for preparing my presentation. And with this, I would like to thank you all for bearing with me, and I hope this presentation was useful to you in some way. Thank you.
Thank you, Aparajita, for taking us through the pathogenesis of acne. It was a very elaborate yet a very lucid presentation. Thank you again. I now invite Dr. Neena Madnani, Madam, from Mumbai, to talk about the newer medical management of acne. Welcome, Madam. Aparajita, can you please stop sharing your screen?
I'm trying to. Just a minute. Just a minute. Can you give me a minute?
Yes.
I'm having issues with this. I don't know why. Stop sharing screen.
So it's the end of the strategic timeout.
Yeah.
Yes. Yes, Neena, Madam, we can see your screen. Madam, you're on mute.
Now, can you see? Can you hear me?
Ma'am, we can hear you, but we cannot see your screen now.
Now, can you see?
No, Madam.
I don't know what's happened. Okay, I'm going to share it again. Now, can you see it?
Yes, Madam, it's visible.
Can I start from now?
Yes, ma'am, please.
Okay. So thank you very much for this invitation. And the topic is so vast of what's new in the medical management. So it's almost like running a marathon in half an hour. So I'm going to just go through like like a whirlwind, and just to give you all a brief of what is there in the horizon on the medical management of acne. So first, before we know what's new, we have to know what's old in the management of acne. So several guidelines were published. You had the Indian Acne, the Philippine Dermatology Society. So 2009, 2011, 15, the AD guidelines in 16, the Singapore guidelines in 19. So lots of guidelines have been published. And this is the guidelines which we had been following, the AD guidelines, which classified into mild, moderate, severe. And we all have been following these guidelines using the topical retinoids, benzoyl peroxide combinations. And then if required, we were adding the oral contraceptives or the isotretinoin. So now let's look at what's new. So the following changes have happened. The AD have a new guideline in 2024. We also have newer formulations with better tolerability. We have newer molecules, and also we have newer applications of older molecules for acne. And previously we thought certain combinations were incompatible, but now we have those combinations ready for use for treatment of acne. So if you look at the new AD 2024 guidelines, the important thing is that they have emphasized that when you see a patient of acne, you have to see the severity, you have to assess it, you have to assess the quality of life, how it impacts you. And in any patient of acne, routine microbiome and endocrine testing is not recommended. And again, they divide it into mild and moderate and severe. And in mild, we have the same topical retinoids and BP are strongly recommended. Topical antibiotics are recommended, but not solitary. And then we have the combinations, the antibiotics, the retinoids with benzoyl peroxide, the retinoids, and they have also emphasized that usage of benzoyl peroxide is very important. And then a conditional recommendation is clascoterone, salicylic acid, and azelaic acid. And when it comes to moderate and severe, you have your systemic antibiotics, and they emphasize use of concomitant benzoyl peroxide and other topical. Most recommended is doxycycline, but minocycline, saricycline, and doxycycline over azithromycin is the conditional recommendation. And then you may need hormonal agents. Again, that you have to choose your contraceptives or spironolactone. And the important thing they've emphasized is that when using spironolactone, if the patients do not have any risk factors, you don't even have to check them for hyperkalemia. And they have emphasized on the need for intralesional corticosteroids in inflammatory acne. And also in isotretinoin, the changes they have emphasized is that patients with psychosocial burden or scarring should be considered, can be considered, and they recommend only monitoring of LFT and lipids. And their population-based studies have shown there's no risk of neuropsychiatric conditions or inflammatory bowel diseases. And for persons of pregnancy potential, pregnancy prevention is mandatory. And then the question of daily dosing over intermittent dosing on either using low-dose isotretinoin or the standard retinoid. So look at the other changes, the newer topical formulations which have better tolerability and efficacy. So what were the problems they faced with the topicals? Retinoids were available in creams and gel, adapalene 0.1, tretinoin, tazarotene, but we had too much irritation, dryness. They were unstable in sunlight, and we had retinoid dermatitis. Benzoyl peroxide also in certain patients caused dryness, irritation, and we have benzoyl peroxide available in gel forms and in combination with clindamycin, adapalene, but was incompatible with tretinoin. What is the improvement we've seen? We have microsphere technology seen in tretinoin formulations, and this has helped to improve the photostability and improve the tolerance. And these microspheres also improve the delivery of these irritating drugs. So we minimize the irritation, resulting in better patient adherence. So tazarotene, none of us have used because it was so irritating, but tazarotene 0.05% lotion, there was a phase 2 analysis for moderate to severe, and they found that the tazarotene 0.045% lotion was well tolerated and substantially reduced acne lesions in both. So it is a newer formulation which is better tolerated than the older formulation. Now the big thing is the trifarotene, which is available in India, which is effective for comedones, papules, pustules. This has a strong selectivity, which translates to efficacy in low concentration. Why is it strongly selective? Because it is selective for the retinoic acid receptor gamma. And it acts in the same way as the other retinoids, but it also has good anti-inflammatory pathway via leukocyte migration, toll-like receptors, and activated protein 1. So this is a big guy on the block. It is approved by the US FDA for once daily application, and it has been studied for facial and truncal areas of involvement. And a study showed that it has negligible systemic absorption after 29 days. So you can really use it on larger areas without any problem. So in this study of patients of 17 to 35 years who were treated with triferrotene cream, it demonstrated about a 52% rate of success in acne clearance as measured by the IGA at 24 weeks. So it seems to be a very promising. We have our own personal experiences with it. We use it for facial and truncal acne. It is safe for long term. And as a monotherapy, it gives continuous improvement over time. And there's a long-term safety study which says it's very safe. And also there was a study showing that it is effective in combination with oral doxycycline. So we can extend its use in patients with severe acne. And the formulation is reported to be easily spreadable, has an elegant texture, and it has low systemic exposure. So in all this, it looks very promising. We'll discuss our experiences. The other newer novel retinoid formulations are in liposomes, microparticles, nanoparticles, micro nanofibers to enhance their solubility, stability, and targeting. And these targeted topical delivery systems offer the advantage of concentrating the active ingredient where it's required. And it also enhances the thermodynamic activity, sustained release. It supports the skin barrier, ease of application. There's so many positives. And the newer retinoid formulations, which we don't have, is the tazarotene spray, which I talked about. Adapalene spray, this actually I didn't know, but a patient of mine who lives in London, she sent me this picture. And adapalene 0.3% gel. What about the combinations which were previously incompatible? So let's look at newer formulations for it. So we knew that certain combinations were incompatible, but now we have a combination of topical clindamycin phosphate 1.2%, adapalene 0.15%, and benzoyl peroxide 3.1% is known as IDP 126. Also, tretinoin and benzoyl peroxide were never compatible, but now both of them are in micro-encapsulated form, so they are living very well together. So in this study of the triple combo, 2 phase 3 double-blind 12-week studies were done where it was used in moderate to severe acne once daily, and the endpoints comprised participants achieving a 2-grade reduction from baseline and almost clear skin. So let's see the results. So at week 12, 49.6% and 50.5% of participants achieved treatment success. And there was greater reduction in inflammatory and non-inflammatory. And most of the adverse effects were of mild to moderate severity. So this fixed triple dose combination demonstrated efficacy and safety in 2 phase 3 clinical studies. It has a synergistic effect of all the components. It gives comprehensive coverage, and we don't even have to be worried about antibiotic resistance. And it makes it very simple for the patient to use a single application. What about encapsulated benzoyl peroxide and tretinoin? So subjects more than 9 years old with moderate to severe acne were enrolled in 2 multi-center double-blind trials. And they show that it provided statistically significant and clinically relevant improvements in both the inflammatory and non-inflammatory lesions and was very well tolerated. Topical minocycline is something we have. It was approved by the Drug Controller of India, and you can see how it helps. So this is when it was compared to clindamycin, you can see that the response is better with topical minocycline. One important factor which came up recently is that when we keep our BPO products outside, and especially in a hot country like India, you have they decompose and they produce benzene, which is toxic. So this study raised substantial concerns about the safety of BPO products currently on the market. And so we need to inform the patients that they need to keep it in a cool environment, but we don't know about the transport. If we look at isotretinoin, we're talking about the leaders formulations which don't require so much emphasis on food. Do we need blood work in young adults before starting? Only a Delphi consensus said only the lipid profile and LFT. Again, there's a controversy of the total dose for isotretinoin. We are still not sure whether it's 120 milligrams per kilogram. Now it's gone up to 220. What is the endpoint? That is still not clear. There was an interesting study of the role of omega-3 fatty acids, which can be given to prevent ocular dryness. And whether you do low dose or intermittent dosing to avoid the side effects, the final results seems equally good. There was another study of isotretinoin which compared isotretinoin with antihistamines versus without antihistamines. I'll talk about later. So then we come to clascoterone. Clascoterone is another important molecule. It comes in 1% as an androgen receptor inhibitor approved for the treatment of acne vulgaris in 12 years and older. It has a chemical structure similar to spironolactone, competes with DHT and other androgens for binding to the receptors, leads to inhibition. And within the body, it is rapidly hydrolyzed to cortexolone, which is an inactive metabolite. Do we have to do any tests for it? No, we don't need to do any tests. Topical, spironolactone. In one single blinded study, it was used and it significantly reduced the comedone count. And compared to clindamycin, it resulted in a more significant reduction. A lot of us use finasteride. So there was a study of finasteride compared to montelukast. So montelukast is another molecule which has been used for acne. And the study showed that finasteride is more efficacious in treating moderate acne than montelukast. And at the end of the study period, 88% of the patients on finasteride had near total clarity of the acne, but we have to be careful in childbearing age. Lasers are a big thing for acne. And this is the latest laser, which is a 1726 nanometer laser. There are two lasers which are available in this wavelength, and they seem to shrink the sebaceous glands and reduce the sebum production to treat acne. Some of them actually produce heat to a temperature of 40 to 46 degrees, which actually coagulates the glands. And these operate at very high frequencies, so they do not cause hyperpigmentation in individuals with darker skin types. So these lasers are very promising. And when they did once a month session for 3 months, they found that the improvement continued. And when they checked the patient after a year, they found that they still had reduction in the acne. Combination of antihistamines with isotretinoins. So we know that H1 receptors are expressed in the sebaceous glands. So in this randomized controlled trial of 100 patients, a combination of isotretinoin and levocetirizine decreased the score of the GAGS and the acne lesion. So this is something we are looking at. You can use desloratadine, you can use loratadine. Again, omega-3 fatty acids as an adjuvant to regulate the gut microbiome. A study was done in rats and they found that it reduced the inflammation effectively. So there's quite a lot of new molecules. We just have to learn how to use them, when to use them. And we have to know our molecules so well that we can use them effectively. At one of our conferences, we had an international speaker who talked about retinoids. And I asked her a question that now there are so many retinoids, which one do we choose? How do we choose? What makes your choice? And the answer she gave me is that pick up any of the retinoids, know them so well, and you will find that they'll be effective in your acne treatment. Thank you very much for this privilege of your time. Thank you.
Thank you, Neena Madam. That was a wonderful and a very informative talk, updating us about the new managements of acne. Gave us a lot of hope as well as confidence. Thank you once again, ma'am. I now call upon Dr. Shomoduti Chandra for her lecture on the management of acne scars. Dr. Shomoduti, please.
A very good evening, everyone. After such strong lectures by stalwarts, I am here to present a very short and summative overview of the options and the newer advances we have in managing the longer and the most difficult sequelae, I would say, of acne, and that is acne scars. So, as my previous esteemed speakers have already said, acne is one of the most common dermatological condition and making it world's 8th most prevalent disease. And 76% of the adults have been seen to be affected by it. And more than that, it has a profound effect on not only the psychosocial aspect, and also have a very negative impact on one's quality of life, because acne is somewhat manageable in some period of time, but once you have an acne scar, that is almost long lasting till it is treated. So coming to what is a scar, so scar is defined as a fibrous tissue that replaces the normal tissue destroyed by injury or disease. What is acne scar? Acne scars are permanent textural changes that and indentations that occur on the skin as a result of the dermal damage caused by the inflammatory acne. Now, because of the dermal damage, there can be two types of inflammatory tissue response. One, there can be an overproduction of the collagen in the tissue, leading to a hypertrophic or hyperplastic scars. So hyperplastic scars can be of two types, hypertrophic or keloid, or there can be a loss or reduced production of collagen in the dermis, resulting in the formation of atrophic type of scars. And predominantly what we see is atrophic scars, which can be of three main variants: morphological variants, ice pick, box scar, and rolling. Now, before we go on to the management, a little bit discussion about how these acne scars form will help us guide the treatment approach in terms of at what stage we should intervene and why. Now, when an acne forms and when it is almost in the subsiding stage, what happens is the first starts with the inflammatory phase, where immune cells surround the pilosebaceous unit and produce inflammatory proteins that around the pilosebaceous units as well as the blood vessels. This causes the post-inflammatory redness as well as a hyperpigmentation. So whenever there is a post-inflammatory erythema and hyperpigmentation, always we should consider that the inflammation is still undergoing, and appropriate management at that stage is also very, very crucial in order to prevent further scarring in that patient. Now, following this, it comes a proliferative phase or the healing phase, where the cells become active to produce structural proteins like collagen and keratin. Following this comes the remodeling phase, where extracellular matrix it gets synthesized, and the scarring process gradually starts in with either overproduction of collagen, leading to hyperplastic scars, or if too much of collagen is broken down, then we have something called an atrophic scar, which I have already mentioned. Now, ever wondered why do some people scar more than others? I mean, there may be people having not much severe acne, however, but the scarring is more intense and more longer lasting. There has been certain uh, risk factors, what studies have documented, multiple studies and multiple researchers have documented and summated that there are some risk factors which are to be considered, which patient may prone to scar. So number one of them is the acne severity, and it is directly proportional to the amount and possibility as well as the amount of scarring a patient can undergo. So more the inflammatory lesions, more deeper lesions, more is a chance that this patient will scar, and that is these are the patients which should be tackled more strongly in terms of more appropriate management, more stronger management, as well as more early isotretinoin use if possible. Next is delayed or no treatment. So longer is a period of inflammation, as I have mentioned. More is a chance of tissue loss by degradation of collagen, more degradation of the collagen, and more tissue loss, and thereby more formation of acne scars. Recent studies have also mentioned that there are certain P. acnes phenotype which induces certain types of skin homing T cells, which are responsible for more persistent inflammation in the pilosebaceous unit, giving rise to more severe as well as more deeper acne scars. So yes, this is all the type of P. acnes causing the acne in that individual also has a role. Now, physical manipulation in terms of picks, squeezes, and pops spreads the inflammation to the surrounding dermis, leading to the formation of widespread and very haggard type of scars. Male gender, it has been found that scars are more common. More severe acne is more common in males, and they are more prone to scars. Maybe because of more sebum production as well as the androgenic effect. Now, family history and the immunogenicity of the person does have an important role, and there has been some studies where there are the people who are by default, if there is a more prolonged and delayed inflammatory response, more is a chance to have scarring. So family history of acne scar also gives a hint when to start more intensive oral management, or when to start a more intensive and stronger oral management in these patients, because they are prone to scar. Again, relapsing acne has more chance of scar. Ethnicity, yes. Important and interesting fact is the genetic factor. Now, the recent studies have found there are some genes, like 3 genes have been found, which has an impact or has increases the chance of having scars in that individual. And very, very interestingly, they have found out the serum markers for post-acne scar. This is very, very interesting, where we can find out the serum level of 2 proteins, that is, one is hepcidin and one is CRP, which can guide us whether a patient will develop scars or is prone to develop acne scars. So this is very, very interesting thing. Next, the Goodman and Barron has laid down some qualitative grading system for acne scars. So this is a very old paper, and traditionally, acne scars qualitatively have been graded into macular, mild, moderate, and severe. Macular do not they are flat scars. They do not have elevation or depression. The mild scars have a mild atrophy, and which cannot be observed at a social distance of 50 centimeter or greater. Moderate scars can be seen at a social distance of 50 centimeter or greater, but can be and cannot be camouflaged by a makeup. Severe scars is obvious even at 50 centimeter and less of a distance, and cannot be covered by makeup or by stretching the manual stretching of the skin. However, more important is the Goodman and Barron's quantitative scar scale, where as mostly patients have a mixed type of scars, quantitative grading is more helpful in evaluating what is the first treatment, or which are the combinations of treatment which a patient may need for a holistic improvement of the type of scars. And so these are every type of scar have been assigned a number, and the total number of lesions have been considered, and this is how the grading system is. Now, how to approach a patient who has come with an acne scar? So first and foremost, a very detailed examination and history taking is important, as like any other disorder, where we do determine the duration of the acne lesions, what are the duration of the scars, what is the Fitzpatrick skin type of the patient, what is the age, and how motivated the patient is to seek treatment. Now, what are the predominant type, as I have mentioned that most patients, or if not all, has a mixed type of scars, morphological type of scars. So what are the predominant type of scars present in that patient, whether what is the depth of scars, which are the more deep scars, and we have to pinpoint those scars, which has to be dealt with or tackled in a maybe in a different way. The location of the scars is again is very important, and why it is important, I'll come to it. Patient's expectation is very most important part of the acne scar management, because we have to emphasize that scar can be made better, scar can be made more aesthetically elegant, and it can be reduced. However, it cannot be made, may not be made zero. So complete resolution, if it is possible, that is good for the patient, but we should never commit a complete resolution of scar. Now, explanation regarding the post-procedure sequelae and all, these are most important, and we have to jot down or formulate a treatment plan, the approximate duration of therapy, and most importantly, what is the cost of the various procedure which may incur to the patient. Now, coming to the acne scar management, once we deal with the scar, most important is to take care of the scar-associated erythema, because as I already mentioned, erythema means the inflammation is still going on. And so if you still leave it untouched, there is a chance that those areas will form more deeper scars. So there are some medical management to it. We can use oxymetazoline, brimonidine, tacrolimus or piperaquinimus, even topical tranexamic acid, even oral tranexamic acid has been found to have a good effect on the scar-associated erythema. We can add some procedures to it, like peels, MNRF, IPL, Quasi-long pulse, or the spectra mode of Nd:YAG laser, gold toning, etc., have been found beneficial to for the post-inflammatory erythema or scar-associated erythema. Now, coming to the topical treatments of treatment options for acne scar, there have been some studies which has shown some benefit on the top on these topical agents, like the tretinoin. Recently, as Neena madam has already emphasized, the combination of 0.3% adipalene and 2.5% benzoyl peroxide. So reducing these retinoids and its combinations reduce the inflammatory cascade in its early course, and it decreases the synthesis of MMPs and increases the dermal collagen synthesis. Antimicrobials, again, it has an anti-inflammatory effect, and it also reduces the long-standing erythema and the long-standing inflammation which goes on in the pilosebaceous unit. So that is again have a beneficial effect on the treatment of scars. Topical steroids and topical tacrolimus, they do have some effect on treating particularly the erythema part of or inflammatory part of the scar. Vitamin C topically and 15% glycolic acid has found some good beneficial role in the acne scar. Tranilast, interestingly, is an anti-allergic medication. It is basically a mast cell stabilizer, and it has been also used in improving the acne scar because of its anti-inflammatory property. Other than that, silicone sheet, mitomycin C,
Shomadati,
these are
5 more
mostly
minutes.
important.
5 more minutes.
I'll just take a little more time, ma'am. So these have been found to be very effective in the hypertrophic or the hyperplastic type of scars. Now, coming to the surgical classification or procedural management of the acne scars. So these are the list. It's a huge list. And now I have divided it into 4 categories. Coming to the chemical treatment, chemical peels, we all know about. This is mostly suitable for superficial or macular type, particularly pigmented type of scars. Mostly we use light peels. Deep peels are rarely used in our in the more pigmented skin types. Next, in the chemical treatments, we have the cross. Mostly commonly, we use a high percentage of TCA. However, 88% phenol is also used for TCA cross. During TCA cross, it is the most effective for ice pick scars. However, very narrow boxcar scars to obliterate the walls, TCA cross can be found to be beneficial. Also, while performing the TCA cross, very careful. Caution has to be maintained to stretch the skin while touching the base of the scar. That is very most important step of the TCA cross technique. Coming to the surgical techniques, one is again most commonly done and should be done for all patients in all sessions of scar treatment is subcision. It basically has an improvement in rolling scars, however can be used for all types of scars. However, ice pick scars hardly gets any beneficial benefit by subcision. It releases the fibrotic strands underlying the scar, leading to organization of the blood and connective tissue formation in that area. Previously, we used to use a knocker needle or an 18-gauge needle. However, nowadays blunt cannula and Taylor liberator is also used for the subcision process. There have been certain modifications of subcision where the needles are bent at 90-degree angle for more controlled subcision and individualistic scar approach in the area. The bent needles mounted on a syringe is also used for a better ergonomic motion control. And again, this is found to be very effective both during subcision, as well as we can also suck out during the process and give a negative pressure impact, which also helps in prevention of formation of fibrotic tracts again in those individual scars. Now, coming to the punch techniques, there are three types of punch techniques which are commonly done: punch elevation or flotation, excision, and grafting. So these are particularly suited for very deep type of boxcar scars, which needs to have a revision surgery. So these are the most important types of punch excision techniques. However, punch excision are usually never done in isolation. They are combined with subcision, either in the preceding or the session or the same session. And even after punch excision or punch elevation, it should be subjected to some kind of a resurfacing laser. Microneedling is very commonly done procedure we know or all know about. So coming to the energy-based devices, and the most important are the lasers. These are the various types of lasers what is basically used for treatment of acne scars. Now, the only thing, a little explanation about how the laser works. So the left-hand side, we have the fully ablative CO laser, which usually it is CO2 or erbiumag. Hardly we use it now. We use it only in one place, and I will be mentioning that. The second comes the non-ablative laser. Again, it doesn't cause ablation of the skin. It causes a cone of coagulation, which causes a more collagen synthesis. The third comes the fractional ablative laser, which causes a fractionated columns of ablation along with coagulation. The fourth comes the fractional non-ablative laser. Now, for fractional laser, only are two most common laser used, CO2 and erbiumag, and this has the level of evidence of 1, and both of them are equally effective and can be used for all types of scars. However, erbiumag, since it has a lesser depth of penetration, causes lesser downtime, more suitable to the patient. However, the response to therapy is more or less same. However, caution has to be exercised while treating patients of skin of color, and has to be emphasized that there will be a post-procedure downtime, and there might be also a post-procedure hyperpigmentation, very commonly encountered in the patients. Now, coming to the non-ablative fractional laser, this is also something which is very commonly used. However, these are this is suitable for more superficial type of scars. They are not very effective for deep scars. However, the most important or the most commonly used indication why they are chosen over an ablative fractional ablative laser is their lower chance of side effects and lower recovery time. So that makes the patient more comfortable to get the laser done during their office hours or during their important events and everything. So another very important energy-based device, which is again has become very popular nowadays, is a fractional microneedling devices. So they create not by they are fractionated devices which create radio frequency thermal zones. So there are two types of needles. So there are needles and there is a radio frequency which is emitted through the needles. Now there are two types of needles which are commonly used. One is the insulated needles, where the entire needle is insulated and only the tip is non-insulated, where only a selected portion of the dermis gets heated up, and that is the area of collagen of coagulation which has to which that can be done, and various levels. It can now the needles can be changed to various levels, so we can start with 2.5 and then we can go to needle depth of 2, and and thereby we can in a single session we can treat 3 different levels of the dermis together. Another type of needle which is which was possibly previously used was a non-insulated needle, whether there is no insulation and the entire needle gets the radio frequency is emitted through the entire needle, forming a very oval shaped structure of coagulative damage to the skin. Now this causes a mild to moderate type of improvement, and it has been found that if you combine fractional MNRF or MNRF in the initial sessions and follow it up with a more resurfacing razor, that gives you the best response to acne scar. So coming to this injectable treatments, there are some injectable treatments which are also done for lasers. Most importantly, fillers. Fillers can be considered for rolling or the box scar type of scars after they have been, subsized, and after there are some sessions of either microneedling or ablative lasers have been done, just to give that textural improvement. Autologous fat transfer is also done, where fat is harvested from the abdomen, converted into a nanofat, and is injected to the entire area through a blunt cannula. Through a cannula, so it not only causes improvement in the scar, it also causes improvement in the texture from the adipose-derived stem cells. And unlike fillers, the longevity of a fat transfer is better. So again, it is economically better. Another very popular treatment is PRP. I think we are all doing it. PRP for acne scar is not a standalone treatment. This is very, very important. We have to combine it with subcision microneedling, ablative lasers, and alike. It doesn't have, a good response is obtained with all types of scar, but not much for the ice pick scars. It also, there are some very difficult to treat linear tunnel type of scars, and there either any kind of a filling procedures, whether it's a filler or a PRP or even a platelet-rich fibrin, which injectable fibrin, which is now used, can be used for that. Now, practical considerations: when we have a different type of scars, we have to denote which are the prominent or the predominant type of scars. Whether we are dealing with a boxcar scar, we can go for a microneedling, punch elevation technique, PRP, etc. If you are dealing with an ice pick scars, the most important is the TCA cross, microneedling, and PRP. If you're dealing with rolling scars, then we have to consider a subcision followed by microneedling and PRP if we do not have that amount of energy-based device. However, if we have the bandwidth to, or the devices, the energy-based devices for boxcar scars, more important is to go for an MNRF followed by fractional laser. I had mentioned the use of where ablative, fully ablative lasers are non-fractional ablative lasers are still used, while we are dealing with a very deep type of boxcar scars. Ablation of the sides or the walls of the boxcar scar to make the deep boxcar scar into somewhat rolling type is done. So on the sides, we do an fully ablative laser followed by fraction laser on the base of the scar. This converts a boxcar scar, which is otherwise very difficult to treat, into a rolling scar, which is somewhat easier to treat. Now, ice pick scars can be managed again with MNRF or fraction lasers, and or PRP, rolling scar, subcision, etc. This is again depending on the scar type. We have to choose which modality to consider first and which modality has to be added later into the treatment armamentarium. This is a list of the level of recommendation for different types of acne procedures. I have just submitted some clinical trials, which has some RCTs, which
Yes,
has
please sum up,
ongoing.
Shobhuti.
Yes, ma'am. Yes, ma'am. Just 2 minutes more. So I will also, there have been some exciting emerging techniques in acne scar management. Picosetin lasers have come up for acne scar management, but then this is mostly suitable for superficial scars. There is autologous non-cultured dermal cell suspension. There is autologous fibroblast culture. This is jet volumetric remodeling. I will just take 1 second for it. Now, this is a proprietary device, and there is only one company who has come with it. It accurately delivers a kinetic energy and a healing component into the dermis simultaneously. So the particles, which are mostly hyaluronic acid based, they are inserted into the acne scars in a single, in a single session or in a single entry point through the epidermis, and it is also, it doesn't have much downtime. So it is one individual and novel technique, and which is currently is gaining popularity. Radio frequency substitution in with radio frequency in the same session. In this manner, it can be done. So this is again a modification of the substitution procedure. Isotretinoin and acne scar management, we have a global consensus that we can start the procedural management for acne scar even when a patient is on isotretinoin. No need to stop or discontinue or give a drug-free interval before we stop isotretinoin and start with the procedural management. So very, very important thing about acne scar is the management of acne scar is to prevent the development of one by adequate control of and adequate treatment of acne. Most patients present with more than one component of a scar. So whether it's a textural improvement or it's an erythema or hyperpigmentation or the scarring, or whether atrophic or hypertrophic. So a new term has been given to these type of scars. It's called the hybrid scars. Always remember, there is no single modality that is universally effective, and a combination of different technologies is the key to success. Thank you so much for a patient hearing.
Thank you, Shobhuti, for elaborately shedding light on the various modalities of acne scar therapy that we have. Now, that brings us to the last of the lectures. And we know that in spite of these elaborate armamentarium that we have for acne, there are often difficult to treat cases that we face in our practice. And so now we have a panel discussion to discuss some of these difficult to treat cases. Dr. Maitri Panda from Bhubaneswar, she will be the moderator for today's panel discussion. The three speakers will be joined by Dr. Abhinita Hostota and Dr. Shreya Poddar. They will be joining the panel. And welcome, Dr. Panda, Dr. Hostota, and Dr. Poddar. Over to you, Dr. Maitri.
Thank you so much, ma'am. So please allow me to share my screen. Yeah, so is my screen visible?
No.
Not yet.
Now.
Okay. Yes, now it is visible.
It is visible. Okay.
Yes.
So before I start my presentation, ma'am, how much time is left for panel?
I think if you can wrap it up in 30 minutes.
25 minutes, ma'am.
Fine. Yes, yes.
Okay, ma'am. Thank you.
We are running late.
Sure. So to start the panel discussion, I have a erudite panelist among us. That is Dr. Neena Madnani, ma'am, Dr. Aparajita Ghosh, Dr. Somuditi, who delivered an excellent talk, Dr. Abhinita, and Dr. Shreya Poddar. And we'll directly go into the case. So it is a case-based panel discussion. So the first case is a case of acne tarda. This was a 34-year-old female presenting with the persistent acne. And she is also on the verge of pregnancy because she's planning to get pregnant. So I will ask, starting from Dr. Abhinita, can you please tell me how do you approach such cases of acne tarda in your regular practice?
Yeah. Good evening, ma'am. This is a wonderful case. So all this while it has been discussed about the ideal cases. So
Excuse
this
me,
kind of
can I
cases
interrupt? Is there some black rectangular thing on her slides, or is it
Yes, ma'am. There are two panels that I can see.
which because it's blocking
And
the
someone reading
writing?
the writing, yes.
Yes. Because we can't read the whole sentence.
Yes, Dr. Maitri, is there a problem on your side?
No, ma'am. Okay, I'll just check, ma'am. I think.
Can you see those two panels?
No, ma'am.
Yes, ma'am.
All of us can see.
Yes,
There
ma'am.
must
Maitri,
be
can you
some.
see?
Ma'am, there must be something in my laptop, I think. So, but then can I?
Can you, screen share once again? Stop
Yeah,
sharing and then
okay,
back.
okay, ma'am. Yeah. I'll do that. So, is the screen visible, ma'am?
Yes.
So, I hope
Panels are
the
still there.
problem is sorted. I'll put the full screen mode. So, is the problem sorted?
No.
No.
So I don't know what to do. So
The
maybe
problem is the selection of the slide.
I think,
Maybe you can read out the printed
yes,
matter.
I think you can continue. Yes. Thomas, we can see the photographs.
Yeah, you
Yeah,
can
so
read out the
basically-
question.
So, ma'am, actually, this is basically a case of acne tada. So, in acne tada, how do we approach to such cases, and what is your routine management options in such type of case? So, I can again request Dr. Abhinita to start the panel discussion.
Yeah. Good evening, ma'am. Yeah, this is a different case of acne tada. Acne tada, first is her age group is 34 and she is planning for pregnancy as well.
Yes.
And as we all, it is for the practitioners forum. So we have to start with the clinical history about her marital status, her obstetric history, her gynec history, because as per the picture, the distribution is along the jawline, and it is more of papules and nodules. So in this case, I would like to take a detailed examination and the history also, if it is a persistent acne or it is just started after 25 years of age. If it is started after 25 years of age, then we need to go into little detail about her endocrine history as well, by taking into account of PCOS, androgenism, and also any features of hormonal instability, and also thyroid profile. And followed by that, we have to I would start her on oral antibiotics to control the inflammatory lesions. Along with that, only on the inflamed nodules, we can try intralesional steroids, 2.5 ml, and not more than 4 to 5 lesions, because as she is planning for pregnancy, we cannot start right away on isotretinoin. And fixed drug combination topically, I would suggest, ma'am.
So, Dr. Abhinita, would you plan to give isotretinoin directly or only with oral antibiotics in such cases?
First, I would try to control the inflammatory lesions, because as soon as we start isotretinoin, there'll be flaring up of acne, ma'am. So I would try to control the inflammatory acne initially, so that the patient will have little confidence on us, and then counsel them of starting an isotretinoin and giving them the uh, uh, proper guidance of isotretinoin, teratogenicity, and family planning, and talk to the spouse as well. If they are willing, then we can go ahead with isotretinoin, or else
And what
just a
would be your choice of antibiotics in such case? Would you prefer a doxycycline or a minocycline, or what is your choice of antibiotics?
Ideally, I would go in for a doxycycline. It works the best, ma'am. But if we are combining with isotretinoin, it's better to avoid tetracycline group of drugs, as it is known to cause intracranial hypertension, that is pseudo.
Yeah.
Azithromycin
I think
macrolide
that's
group
the
of
more of
drug.
theoretical risk of pseudotumor
Yeah,
therapy. However,
yeah,
yeah, we should have us, even the ethical and safety profile should be maintained. So
yes, ma'am.
I would like to ask Dr. Shreya, would you combine oral antibiotics or oral isotretinoin with chemical peels to manage acne tarda cases?
We can do that. We can do salicylic acid peels for this patient because
Okay.
she particularly has papillary lesions. We can also do a black peel for this patient. I think it would work well for her. And isotretinoin is no longer a contraindication for peels. So we
Yes.
might as well add peels to her regimen because that will only fasten the recovery process. Also, I
Yes.
would like to evaluate her for signs of hyperandrogenism. I would like to do an endocrinological complete workup in terms of testosterone, LH, FSH, prolactin, AMH, and a thyroid profile, and refer to endocrinologist for starting hormonal therapy because that is going to help her, fasten the recovery process. And
Yes.
in case she's planning for pregnancy, I would just put her on topicals. I would avoid any antibiotics or isotretinoin
So
for the
which
time.
topical would you prefer for if somebody is planning or somebody becomes pregnant? Which topical antibiotic?
Yes. So, ma'am, I would actually give clindamycin if there are very pustular lesions. And if for this patient particularly, she has some hyperpigmented lesions also. So I think azelaic acid would work well for her. So
Okay.
azelaic acid twice daily, maybe for short contact because sometimes it can cause a little bit of irritation.
Yes.
So I would put her on azelaic acid twice daily and ask her to continue throughout her pregnancy because that is pregnancy safe.
Yes. So we'll like to
And
sum
I
up
would
this.
want to
Yes.
add some.
Yes, Dr. Aprajita.
Yes, because firstly, I think if she's planning for a pregnancy or she's in case she does become pregnant, I think a bit of counseling is a must because during pregnancy, acne might behave very erratic. So it's very important to tell her that your acne, how it is going to respond, and especially only to topical therapy is not it's not very predictable. So we might not go for too much of aggressive treatment at all in that stage.
Yeah. So counseling is also a very important factor in any disease management. So moving over to the next case. So this is a very typical case of topical steroid damaged face. And the patient has been applying topical triple combination cream for more than 1 year. So I would like to hear from Nina ma'am. Ma'am, how do you approach and manage such cases of TSDF in your practice?
But these are very difficult cases because the actual reason for them to use a topical steroids in India, most of them want to become fair. So, and they get a great fairness, which they love. So, but what happens is after some time, they start getting these eruptions and they start getting the burning sensation. And they talk about when they go out in the sun, it becomes red, or when they have something spicy, it becomes red and it gets very itchy. And that's when they come to us, when the eruptions reach such a stage. Now, what topical corticosteroids do is so many things on the face because they cause the vasoconstriction, they cause immune suppression, the barrier function is impaired, they cause atrophy. So you have a lot of things happening. They almost look like rosacea, they look like pitiosporum folliculitis, they look like demodex. It's just a combination of the whole clinical picture. Now, our first job is to stop the corticosteroids. and to convince the patient, but the patient knows that the moment she stops, she's going to get dark again. So we have to convince her that we will give her other things to make her a little brighter, not fair. Second thing is the moment you stop the corticosteroids, within 2 weeks, they get a very severe flare, which then makes them want to stop whatever you're giving. So that you have to warn them about it, but promise them that after that, they'll be clear. With these sort of patients, what I like to do is it's very itchy. So of course, I'll give them an antihistamine. Second thing is I like to add a low dose isotretinoin because I feel that really works very well. The topicals, I find that tacrolimus irritates the skin. My patient somehow cannot tolerate topical tacrolimus. So I don't use tacrolimus, but I would use my isotretinoin. I may use a little bit of benzoyl peroxide, and some of them are so difficult that we have to move from the super potent to the medium potent to the mild, very slowly phase them out. But this is a tough job, and it requires a lot of hand holding, lots.
Ma'am, so in such irritated skin, what is the low dose of, 10 mg isotretinoin, or which is
I
the
would
dose?
start with 5. I will start with
5
5
mg.
milligrams
Okay, ma'am.
and give it to them for about 10, 15 days. And
And
they,
ma'am, in your practice, sorry to interrupt, ma'am, in your
Yeah.
practice, would you like to add up sunscreens and moisturizers?
that of course, that skincare goes without saying. So you'll use a very gentle face wash. You're not going to use any of these acid face washes. You're going
Exactly.
to tell them not to rub their face, dab it dry. They will need to use a little emollient because their barrier function is damaged. And of course, sunscreen is very important. But I prefer to tell them to just lightly cover themselves up because even sunscreen sometimes stings because their barrier function is really, really, sort of finished. And some of them with the pitiosporum folliculitis, I may even give them a cover of fluconazole.
Okay,
Or I may even sometimes give them ivermectin as a topical
Yes.
application because you may expect Demodex to have,
Yes, ma'am.
cause very much inflammation.
Ma'am. So here, I would like to ask Dr. Abhinita, would you prefer peels and any cosmetic procedures in TSTF pigmentation?
Not in the first sitting, ma'am.
Okay.
Probably first sitting, as Nina ma'am said, the more so their photo protection, the regular cleansing routine, and the moisturizer is very important so that the skin can go in for the further peels and other procedural
How long should we wait? The treatment first follow-up should be at the end of how long? What is your regular practice?
I would ask them to come every 15 days, ma'am.
Okay.
So that we'll know how whatever we tell them, whether they have put that into practice or it is just the theory they have heard and gone.
Yes.
So as per their reports, we can customize the treatment because there is no standard treatment for TSDF. It is all, as ma'am says, it is symptomatic. We start to treat them depending on the symptoms.
Yes.
So once that is repaired, probably we can go in for further deeper therapies.
Yeah. So basically for TSTF, we should maintain with less oral antibiotics or maybe very low dose of isotretinoin and rather focus on the topical modalities and restrict ourselves. Even I have tried with pimecrolimus and tacrolimus. If there is a proper way to counsel these patients, they do respond well. However, the concerns of irritation is always there. So again, continuing with the same TSTF context, this was a case of following use of chronic use of, I think she had used some Pandem Plus, and this is the erythema she developed. So I would like to hear from Dr. Shomoditi, what would you do in such situations? How to prevent the erythema and telangiectasia?
This patient has already developed a very widespread thinning of their skin, including the entire cheeks. Even the chin area is already thinned and very prominent dilatation of vessels. So again, the first step is to stop the whatever steroid has been used. Yes, for a very high potent steroid to be which is used for a very long time, some kind of a de-addiction regimen just helps to prevent a flare of maybe even the dermatitic component as well as the redness component. So after the initial management, if I'm only talking about the telangiectasia, my choice, I start with an oral anti-inflammatory, which usually includes maybe doxycycline in a low dose, sunscreen at this stage. Initially, if the patient is having a little dermatitic component, I do not give a sunscreen. I ask for physically covering the area with a scarf or a hat or whatever it is, moisturizer, and and a cleanser, very mild moisturizer. The moisturizer should not have fragrance and paraben. I emphasize on that. And and it is like a frequent use, depending on how skin is getting reacted and how skin is getting dry or itchy or something. And of course, antihistamine. Now, if I talk about only so apart, and I do also, depending on the type of tolerance of the patient, either I give a low dose tacrolimus. So I start with even if I give a tacrolimus, it has to be on moisturizer, and I start with a 0.03% once a day application on the patient. I may increase depending on the tolerance of the patient. Another thing which I give for the erythema is a topical tranexamic acid, which I found to be very useful. It is very slow acting, however, it is useful. So these are the two things which I have found very useful in my practice. I do procedural management on this patient, like if I choose a peel, the peel is a lactic acid peel, which helps in restoring the barrier function. The lactic acid, because of its moisturizing action, helps to take care of and enhance the lost barrier. Number two is laser for the prominent telangiectasia. What I use is a gold toning, which is it's a 694 nanometer device. If otherwise, we can also use an IPL with a vascular filter, and repeated sessions are needed to take care of the telangiectasia portion of the erythema component.
But that laser part and all procedures should be at least restricted, at least not up to the first 4 weeks.
No, so first, for after the initial management, if I'm only taking care of the telangiectasia with medicinal management or the medical therapy, telangiectasia doesn't respond that well. The overall background redness does respond, but the telangiectasia, if the patient wants that I want to treat. So after the initial management, if I'm putting a patient on or managing exactly the telangiectasia, I would consider these procedures to be add-on to the therapy.
Yeah. And here, Dr. Aprajita, I would like to ask you, any experience with topical brimonidine?
I did use it in quite a few patients initially, but I was not very happy in the sense that it used to, the rebound is too much. The moment they stop, there is a lot of rebound. So currently what I do is mostly moisturize, and a physical sunscreen. And I let time take, the patient takes some time for the skin to heal on its own.
Okay. So moisturizer and sunscreens and
physical sunscreen, a physical sunscreen.
Okay. And again, you believe in calcineurin inhibitors, topical tacrolimus, pimecrolimus?
Very less, because I've had a few experiences where patient has complained of too much of stinging with the topical calcineurin inhibitors.
Okay.
Especially in the initial stages.
So here, where's that? This is where the use of tranexamic acid has a very good role.
That is
topical tranexamic acid. Yeah. So
Ma'am, pimecrolimus, if I may add, is not too bad. I mean, I give pimecrolimus to
yeah.
So ma'am, I give pimecrolimus to all my patients of TSDF. Tacrolimus, they don't tolerate usually, but pimecrolimus being in a cream formulation, after applying the moisturizer at night, I have seen that most of my patients tolerate. So as a step down from high potent steroids, we can give pimecrolimus for 2 to 4 weeks and then move to other treatments, just to restore that skin barrier and tackle the side effects that
Yeah,
steroid has caused over
absolutely.
a long period of time. Also, it takes care of the erythema also. As you mentioned, these two papers, tacrolimus also takes care of the post-acne macular erythema. And even in cases of TSDF, it does take care. So tacrolimus can be mixed with their moisturizer and maybe then applied to prevent irritation and kept in the fridge also. That is another way we can try to use tacrolimus in our practice.
So that is very
I have an objection to, mixing tacrolimus with a cream. The bases are different. The bases are different. So a tacrolimus ointment and a moisturizing cream may not go together. I may not really mix that way.
No, Dr.
And if you're
Aprajita, what we
mixing
can
it,
do
it's
is,
getting diluted.
yes,
Yes, the final
Layer
concentration is
it.
the
yeah. So we can. So moving over to the next case, this is a typical case of seborrheic melanosis because always we have these two overlap features when the patient comes of acne and the patient also complains with this type of presentation. So my panelists, can you just have your approach to this type of cases because this is very familiar with the Indian context. So Dr. Neena ma'am.
So this, what we call seborrheic melanosis is, like you said, it's mainly in the Indian subcontinent in
Yes,
Asia. It's been described as an entity. I think we have few papers from India of this entity. But when I look at your pictures, I mean, and I think of the patients I have, you've written that no atopy and no rubbing the areas. But when you look at the areas which this thing with the erythema and all, even when they say we don't rub, they rub because they are trying to remove this sort of sticky thing and the pigmentation. So it's a combination of effects. So the thing is you need to reduce it's an inflammation after all. So what I do is I give them a combination of antifungal and a mild steroid. I give them that to use because once that settles, the thickness settles, then they are more amenable to not rubbing because what the pictures you're showing me is a combination of things.
So ma'am, here when you were mentioning about topical steroids, so which topical steroid and for how long? Because there is always a risk of rebound perioral dermatitis.
Correct. So I would use just your combination of say clotrimazole with a mild steroid. Like I may use hydrocortisone as a combination and just for a week to give them that relief. And then I think now, since it is also like a little dermatitis inflammation, now I think we can even start using the other things like crisaborole, which can also reduce the inflammation. And like the other said, then finally we go into pimecrolimus. Sometimes if we find there's Demodex population is very high, then we can give them ivermectin and we can give them a topical ivermectin also. So this also is nothing standardized for it because we really don't know what is the exact cause and how a patient behaves.
Ma'am, whatever literature I went through, it is like something it's a modified type of seborrheic dermatitis.
Correct.
That is what, so basically.
So they also, we use the antifungals.
So here, ma'am, in such cases, I mean, Dr. Shreya, can you just, your experience of using any peels in such type, glycolic peel? I have seen few prescriptions of using glycolic peel in seborrheic melanosis.
If anything, it should be salicylic. Because
ma'am.
salicylic, not glycolic. Glycolic may irritate more.
So there where the catch is, ma'am, can we use a glycolic peel for only to reduce the pigmentation or maybe a lactic pyruvic combination? So does it actually help? My experience is very minimal. So I just want to hear, Dr. Shreya, would you like to speak?
Ma'am, my experience with peels and seborrheic melanosis is very minimal as well. So if there is some erythema, there is some active inflammation, we have to first use a mild steroid, as ma'am mentioned, like a hydrocortisone or maybe a tesonide. And when that is taken care of, it's just the greasiness is gone. It's just the pigmentation that is there. Yes, peels theoretically can help to minimize that pigmentation. It can be a glycolic peel or a lactic peel, but it has to be done repeatedly. A single session won't suffice. So I think theoretically, yes, it should help.
So it should be a chronic use. I mean, nothing helps in a first or two sittings. Yeah. So again, what ma'am told, constant rubbing and this frictional part should be avoided in such type of cases. So moving over to the last case, maybe we'll sum up in another 5 minutes. So this is a classical case of hormonal acne because the 23-year-old girl, she never responded to any, even in spite of multiple uses of oral retinoids and antibiotics, the lesions still come up. So here I would like to hear from Dr. Abhinita, how do you approach a case of hormonal acne? Like if the first time when the patient comes and when you have a background history of not responding to regular treatment, so what will be your approach to such case?
Yeah, first is a clinical history of why this hormonal acne is happening, ma'am. It should be like, in conjunction with the gynecologist and an endocrinologist as well.
Okay.
And then we have to get their hormone profile done. Since they are not, we have tried and tested all possible topical and oral, algorithm of treating acne vulgaris. So in these cases, we do the hormone profile, which includes, as Dr. Shreya said, it includes testosterone, the serum testosterone, then DHES, and then LH-FSH, the ratio, and also the ultrasound scan also to rule out any PCOS is there. And then I would start her on oral contraceptive pills, but only in case if she has anovulatory cycles or at least more than 6 anovulatory cycles, or she has missed her cycles for more than 45 days, then probably under the interdepartmental on conjunction with the gynecologist, probably I can start her on oral contraceptive pills. And also, if we have to rule out any insulin resistance is there in these patients. In that case, probably we can, even the metformin 500 to 1000 mg per day will give good results.
So how long do you write in your prescription? What is your average duration of therapy? If you start metformin, or do you refer to the endocrinologist directly?
First, we have to do, since we are doing the ethical practice and now that consumer court and everything is there, it's better to have a word with the endocrinologist before starting the metformin.
Okay. And Dr. Shreya, what is your take on hormonal acne? Would you like to start, which is your molecule of choice? After doing the investigations, if there is no such, if you do not find any pathology in the adrenals or maybe any, only the raised testosterone levels, then how do you approach such cases?
Ma'am, I would refer to an endocrinologist. I do not usually like to start the pill myself. So it would be better if it comes from them. Me starting metformin coming from an endocrinologist would be more acceptable to a patient. So I usually refer to them, and I also start them on some anti-acne medications. It's not just hormonal therapy that is going to suffice. So topical and anti-acne medications also we have to give.
So
and the cause
what
of
anti-acne medications?
So, ma'am, for this patient, I would start her on isotretinoin because she has nodular
She
cystic
didn't
severe
respond actually. This case was a very difficult. This is one of my patient only, and currently she's on hormonal therapy. So she didn't respond to any antibiotics. I have given a course of doxycycline, azithromycin, minocycline, then also chronic use of isotretinoin. Every monthly she has a flare, premenstrual flare, and then the whole thing continues.
Then, ma'am, combined oral contraceptive pills would be the choice for her.
Yeah.
Estrogen
So
with
that,
progestin.
yes.
That is the ideal choice. If she has a premenstrual flare and raised testosterone levels, this should be the ideal, but it should be started after consulting a gynecologist or an endocrinologist.
Both gynec as well as endocrine. Yes.
Yes. And ma'am, apart from that, myo-inositol, zinc, lipoic acid, all of this also kind of regularizes
yes.
Restores that imbalance in the body and restores your metabolism. So that is something that I like to add along with that.
Yes, so oral contraceptives is a very good option for such patients. And Dr. Aprajita, any other molecule we would like to start? Like Shreya told about myo-inositol. So about in your practice?
No, I am usually happy with a combined oral contraceptive, but then I'm more, in favor of an oral contraceptive with it in a low dose estrogen with cyproterone acetate. That is what the combination I
Yes.
prefer.
Okay.
And I do add metformin. And other than this, not that I want to know regarding clascoterone, if that becomes available. I'm not sure if that cream is available in India. The
In
newer
India,
one, which is a
currently, it's not
topical.
available. Yes.
Yeah, it is currently not available. Though when I was looking for it, it was available in one or two online sites. I don't know, some
Okay.
India Mart or something. But that should be, if it comes in India, that should be an interesting
That
option
would be
to
an
try.
interesting option. Yes. So, and Dr. Somoditi, would you like to add cryotherapy in your? Do you have experience of using topical cryo or intralesional ILS in such cases?
So cryo on face for acne, I usually do not do, for the sole reason it has a chance of depigmentation, which I am a little wary of. So I do not do cryo on face for acne particularly. So instead, if the patient is having a high serum testosterone, it is actually logical to put the patient on oral contraceptive having either sapropterin acetate base with ethinyl estradiol or a drospirenol base to take care of it. Otherwise, only giving an anti-acne medication panel, whether it's an oral and mixture of oral and topical, it is not going to help, and it is also not going to help with the premenstrual flare. So a combined contraceptive pills with an oral anti-acne medication will be given. If I'm talking about the procedural management, this patient also has a lot of comedons. So before I even plan the patient for an isotretinoin, peels and comedon extraction, I would be, more comfortable doing it, because for a isotretinoin induced flare, these are the comedons which cause the flare, which are the one which has been found to be the most common cause of isotretinoin induced flare. So I would be doing peels with comedon extraction, and
Comedon
if there are
extraction, yes.
nodules, I would do an ILS on it. Also, if they are extremely inflammatory acne, and for individual lesions, if I'm not doing ILS, it's just an option. If I'm choosing one laser for those inflammatory acne, I would do a quasi long pulse Nd:YAG laser on the inflammatory acne, because it has shown to have a sebostatic as well as it is anti-inflammatory, and it has a antimicrobial effect also. So
Yeah.
This is just an add-on. I'm not putting this is just an add-on on the procedural aspect, just for the purpose of discussion. But yes, this patient definitely requires a hormonal management in addition to the standard methods of acne care.
Absolutely. So I would like to hear from Nina ma'am, probably the last say. Ma'am, we'll wind up the panel with this, your take on hormonal acne.
So my take is totally different from what y'all all have said. So can we go back to the picture?
Yes, ma'am. Ma'am, actually here I would like to ask your experience also with oral spironolactone, because currently the patient is on spironolactone.
So this patient, she's 23-year-old, unresponsive. So like everyone said, first you rule out whether it is hyperandrogenism, hyperandrogenemia. So here you can see she's got oily scalp. And you can see the inflammatory, she's got moderate to severe nodular cystic acne. So we ask her questions about her periods. So suppose she has no other signs, and we have to then think of how are we going to settle this inflammation. Now, as a previous speaker said, yes, you can see the close comedone. So first thing I would do, the comedone, I don't express the comedones, I hyfricate the comedones, and they form little scabs and they fall off without a scar. So I hydrate the comedones. Second is she has so much inflammation, she will not allow you ILS and all the things. So I may give her a short course of oral corticosteroids to bring her under control.
Yes,
And my favorite is spironolactone. I only use spironolactone in these young people. I'm a little wary about using oral contraceptives because if she doesn't have irregular periods, I don't want to use oral contraceptives. And oral spironolactone, I am very happy with the results. I give 25 milligram twice a day, and we explain to the patient that it's going to take you a little time. Although retinoids are indicated topical for all acne, I think that when they are so inflamed, I would rather give a benzoyl peroxide clindamycin combination to use to calm it down. But definitely, I would think of a short course of systemic corticosteroids, hyfricating the comedones, and spironolactone. That is what I would do. And although it's recommended 100 to 150 milligram, in my experience, even 50 milligrams a day is superb. The whole thing just sort of, the comedone seemed to disappear. Even without doing comedone expression, you'll see everything quietening down.
Yes, ma'am. My experience is very similar to what you have said, ma'am. Oral spironolactone has an excellent response in youngsters. So even
in
my
older people also, it has
yes,
an excellent response.
Yes, ma'am. I have more better experience with these youngsters. So, and I do use a lot of cryo also. But what Somriti told, there is definitely a concern for hypopigmentation. And sometimes I also do some peels. But whatever the background stays, oral metformin, oral spironolactone, and ocipils, they are the pillars of hormonal acne. So
The
we should
other, sorry,
yes.
one more thing I forgot is you can also give finasteride.
Absolutely.
Because she is unmarried, this is the best time you can give her finasteride.
Yes, ma'am. Absolutely. So we come to the end of this panel discussion. I would like to thank all my panelists and also thanking the West Bengal IDVL Academy, Sudeep sir and Sujata ma'am for giving us this opportunity. And over to Sujata ma'am. Thank you so much.
Yes, Maitreyi, before you wind up, there is one task left. Very important. You have to answer the audience questions.
Absolutely, ma'am.
Yes, so we have 4 questions. So 2 of them are related. I'll read it out to you, all of you. One is how to manage the erythema of acne once the acne is controlled. And a related question is topical brimonidine, how to prescribe, whether it is overnight, whether it is a short contact therapy, whether you want to give it daily or you want to give it on alternate days. I think Shomaduti had covered a bit of acne associated erythema. So, Maitreyi, it's your call.
Yeah. We had discussed about topical brimonidine. So, ma'am, in my practice, I usually give for short contact. I do not give it for overnight. And the problem with that molecule is the rebound flare. So once you start, so you have to very slowly taper it out. Maybe alternate day, weekly once, weekly twice. That is how we start. And it should be given not less than 4 weeks. And beyond that also, there is a rebound flare the moment you stop. So for acne erythema, sir, madam, my first choice would be a pimecrolimus or a tacrolimus rather than brimonidine. But however, if any of the panelists have something to differ, kindly the panelists can speak up.
I agree with you. I'm not so fond of brimonidine because I see a lot of rebound redness. But one thing which I find works in this is the IPL. That works really well to reduce the redness. You do it once in 2 weeks, you do about 4 sessions, and they do get a reduction in the redness.
Yes. Somebody has asked to compare topical ozenoxacin with topical minocycline. Your experience.
Yeah, ma'am. Probably many of the postgraduate theses are going on this topic. So my experience so far with one of my postgraduates is topical ozenoxagen does work in mild papulopustular and grade 2 acne. But beyond that, ma'am, only topical therapy is, and minocycline, the issue is some type of pigmentation, some yellowish pigmentation it leaves behind. And sometimes even it is more photosensitive. So probably ozenoxagen has a better say in if it is a topical preparation. So
Yes.
I think any of the panelists would like to speak on this.
I think I have had experience with topical minocycline, and the important thing is that it gives a yellowish discoloration. So you don't tell the patients to use it and go out in the sun because it looks yellow. So they do it towards the night time, about an hour or two before. And by the time they are ready to sleep, a lot of it is absorbed. And I asked them to put a sort of a different sheet on the pillowcase so it doesn't get stained with the pillow. And if it is stained, if the pillow is stained, and if you use hot water, the stain will never come out. So you have to wash it with cold water. So my experience with topical minocycline has been quite gratifying. So, I'm quite happy with minocycline. I don't think ozenoxagen is a molecule we should be using. But again, there's a fear about topical minocycline causing resistance. So that is a big controversy.
Yes, I think the most important thing that the message that should go out to the PGs is that either of them should not be used as a monotherapy.
They should be used with benzoyl peroxide. So you
Yes.
use a benzoyl peroxide wash,
Yes,
and you use the
used as a
minocycline.
monotherapy.
Yes.
Yes. Yes. So coming to another question, somebody has, Dr. Poria has asked, what is the prerequisite for procedural management of acne scars? Prerequisite for procedural management.
Dr.
I am
Somodati
not
can
very
take up
sure
this
I
question.
understand. Yes, the what has exactly been asked. But this is the question. What is the prerequisite for procedural management of acne?
Consent
I'm
forms.
also not very sure about the
You have to take a
question.
consent form. That is your
Consent form.
prerequisite. You have to evaluate the patient properly. And like the speaker spoke beautifully about how you have to tell them what to expect with your procedures, how many procedures, the cost of the procedures. I think that is all the prerequisite which is required before you do a procedure.
So, with this, we come to the end of the panel discussion, excellently moderated by Dr. Maitre, with invaluable inputs from all the panelists. So the acne update has taught us that several newer aspects of acne pathophysiology is there, and hand in hand comes the possibility of newer therapeutic options, not only for acne, but also for acne scars. So overall, it was a great learning experience. I now call upon Dr. Shuchibrata Dash, who is the Secretary, IDVL West Bengal branch, for his concluding remarks.
Thank you, Dr. Sujata Madam, for excellently well coordinating this fourth episode of Derma Adhyayan. On behalf of IIDL West Bengal, I express my regards and heartfelt gratitude to all our erudite faculties, both national and local, for making this fourth episode of session one of Derma Adhyayan a complete success. Actually, this is organized solely by our women dermatologist wing of IWWB. I'd like to thank all the attendees for their active participation in one of the most common and most distressing disease in dermatology, acne. The discussion was practically very impressive and immense knowledgeful. I am thankful to Dr. Prajita ma'am for giving the newer insight about the pathogenesis of acne, Dr. Meena ma'am for newer medical management, and Dr. Somodati for surgical management of scars. I would also like to thank Dr. Maitri Panda Madam for excellent moderation of the panel discussion on difficult to treat cases of acne, and all panelists, including Dr. Abhinita and Dr. Shreya, for their insightful thoughts about those type of cases. I would also like to thank our dynamic president, Dr. Sandeepan Dhar sir, our inspirational first president, Dr. Kaushik Reddy sir, ever youth Dr. Sudeep Das sir, our president-elect Dr. Dinesh Haulia sir. And at the end, I'd like to thank Pulsar Derma for their wholehearted support to make this program possible, and all our office staffs. Good night. Good night to all.
Thank you.
Ma'am, can I take a picture, please? First, if everybody can switch on their cameras, please. Aprajita, ma'am, if you're there, can you please switch on your camera? I just wanted to take a picture. Yes. Just take a picture. Thank you. Thank you.
Thank you.
Thank you for
Thank you.
fantastic moderation.
Thank
Thank you.
Nina ma'am,
Thank
take care.
Thank you.
Hope your sister gets well soon.
Thank you so
Sujata
much.
ma'am, thanks a lot.
Thank
Bye,
you all.
everybody.
Good night.
Thank you.
Thank you.
Thank you,
Good
sir.
night.
Thank you.
Good night.
Thank you.
Thank you.
Thank you.